All right, so I'll try to stick to the limit, but then I'll need to focus on only 20% of the material. But there's something called the 80-20 rule, so I'll try to focus on the 20% material that hopefully will cover 80% of your patients. I'll be talking mostly about diagnosis and treatment, so we can go on directly to the differential diagnosis. For knowing the differential diagnosis, I think it's very important to realize that most of your patients with diabetic neuropathy might have with diabetes might have diabetic neuropathy as the reason for their symptoms, but that does not mean they cannot develop any other kind of neuropathy. Of course they can. So if the pattern of your patient's problems don't fall under diabetic neuropathy, it's very important to think what else can it be. So what is the pattern of diabetic neuropathy? The pattern of diabetic neuropathy is symmetric, equal on both sides. Length dependent, so more in the legs than in the hands. Small fiber, and we'll talk about small versus large fiber. Neuropathy, so diabetes does not usually cause a myelopathy as such, and you need to be sure that you're not dealing with the myelopathy. So symmetric, length dependent, small more than large fiber, neuropathy, that is you need to rule out a myelopathy. So let's talk about the first kind of warning bell in that sequence, asymmetric sensations. So what if the sensations are asymmetric? What are the possibilities? One possibility is, of course, a radiculopathy. A radical means a root. So compression of the nerve root somewhere in the spinal cord due to a disc. And that can produce a C5 radiculopathy which goes into the shoulder, or an L5 radiculopathy which goes into the great toe of the big foot. But it will be asymmetric. It will be more usually on one side than the other. The second thing is diabetic amyotrophy, which we'll talk a bit more about, and entrapment of the nerves, which again we'll talk a bit more about. Rarely, diabetes can produce other symptoms like mononeuritis multiplex and leprosy. I'll just mention one other rare thing that you will come across every once in a while quickly. So that is treatment-induced neuropathy or treatment-induced neuropathy of diabetes. So what happens is this patient comes to you with a poorly controlled sugar and you give him some insulin or something very nice medication, and suddenly the patient comes back to you, "Arte te औषध दिलं ना त्याने ते पाय जळजळ करायला लागली एकदम. तुम्ही काय औषध दिलं?" That is a consequence of the treatment, a transient consequence for which your treatment doesn't need to change, but you need to control the pain in the short term. So that is called TIND, or treatment-induced neuropathy of diabetes. Two things I promised we'll talk a bit more about. One is diabetic amyotrophy. This is a person who has type 2 diabetes mellitus, and just like the TIND person I talked to you about, this person will complain of severe pain. But as we are talking about asymmetry, they'll complain of pain on one side, and sudden pain radiating to one leg, and you will think this is a radiculopathy. And that is certainly that's something that you need to rule out by doing an MRI. But then the imaging is normal. One thing to rule out is a psoas hematoma, which sometimes can produce features like this. But eventually, very slowly, the pain decreases, but there is significant atrophy of the leg. And every once in a while, you will see this. Very rarely, it can happen in the upper limb as well, but usually it is the lower limb that is affected. The second thing, and I think this is more important and much more common than diabetic amyotrophy, is entrapment of nerves. So we'll talk about two entrapment symptoms in the lower limb and two entrapment symptoms in the upper limb. So the two in the lower limb to remember, one is meralgia paresthetica. That is the lateral femoral cutaneous nerve. So right here, where the anterior superior iliac spine is, below the inguinal ligament, a small cutaneous nerve passes and it supplies the lateral side of the thigh. And these patients will come in and and they will be classically overweight or might have put on weight and are still using the older clothes. So they'll kind of put their clothes a bit lower here exactly, and they'll complain of burning pain here. The second thing that can happen, and this is very common in obese people, of course. The second thing that can happen is when sometimes we have an habit of crossing our legs or resting our legs to the side of the chair, and then there can be compression of the common femoral nerve at the fibular head. So when the common peroneal nerve at the fibular head gets affected, it supplies the dorsum of the foot. So the pain, again, a burning pain will be in the dorsum of the foot. Now in all of these entrapment neuropathies, there is something called the Tinel sign, which we might have heard of in reference to carpal tunnel syndrome. But basically, wherever the nerve is compressed, if you hit on it with a hammer, they'll get radiating pain down there. And that pretty much confirms the diagnosis. So when Mama had come to me 2 days ago, he was complaining of pain in these two fingers. And I hit this part, And he himself was convinced, ha tras hai. So the doctor is convinced, the patient is convinced, nothing better than that. So no EMG nerve conduction required in those cases mostly. Warning bell number 2, as I said, symmetric length dependent. Length dependent should be more in the legs. But let's say the patient gets it more in the hands. Then what? Of course, it can be any of the other things that we discussed. It can be a radiculopathy, it can be entrapment, and we'll talk about entrapment. It can be a diabetic amyotrophy, which rarely can happen in the arms as well. And it could be rare conditions like leprosy or vasculitis. But one thing to remember is if a person comes to you with neuropathy in the hands, numbness in both hands, even if it's painful, and is complaining of weight loss or something that makes you suspicious, weight loss, severe fatigue, fever, unexplained fever, that can be an autoimmune condition. That is one scenario in which you would jump to a huge test, a PET of the whole body to rule out a malignancy, and it would be worth it to do it in that patient. The exact names of the antibodies are not that important. We talked about 2 entrapment neuropathies in the lower limb, and 2 entrapment neuropathies I told you we talk about in the upper limb. One, all of us are common with, this thing. So carpal tunnel. People who are typists or writers or even doctors, they might get carpal tunnel, and the pain is usually in 2 fingers or 3 fingers. Classically, it will split the finger, the middle finger will be split, but there are changes in sensory distribution. But one thing we often miss noticing is the one that I told you about with the mama. So the mama, actually, I found out what was causing the compression. The mama used to have a resting chair at home, and so he used to sit down with his wife on the same resting chair and support his wife with his one arm. And exactly at this point, he was resting that arm, this part, over the arm of the chair, and that's why he had the neuropathy here. That's ulnar neuropathy at the elbow. That's the only thing that he needed to do. He needed to stay away from his wife and is better. So what's that? Large fiber neuropathy. So we talked about how small fibers and large fibers, but it's important to realize what the small and large fibers are. These are not small and large nerves. No. Each nerve will have many, many different fibers. Some of them are very large and some of them are very, very thin. The larger fibers are large because they have a coating of myelin or a coating of fat. And these fibers actually conduct the sensations that are most important, most time dependent. So let's say you're walking, you really want to know कि आगे पत्थर से अपना गिरने वाले है कि नहीं गिरने वाले. So joint position, for example, is conducted by the large fibers. On the other hand, if it's like a burning kind of pain, probably a bit of delay is probably okay, not as critical as proprioception. So the small fibers actually conduct pain and temperature. So again, the large fibers, which are there in every nerve, every single nerve, conduct vibration and position sense, and the small fibers, which again are present in every single nerve, small or big, conduct pain and temperature. All right, so that's that. And you can see the myelinated nerve fibers and the unmyelinated nerve fibers in the same nerve. So what kind of pain do these fibers produce? It's very important. The patient will come back and tell you, I have burning pain in my limbs. So that's small fiber pain. On the other hand, if the patient says, I have this shooting pain, दोनों तरफ से खच कैसे ऐसे नीचे जाता है और बाद में रुक जाता है, खच कैसे नीचे जाता है और बाद में रुक जाता है, that is not small fiber pain. That is large fiber pain. Classically, the etiology that produces that kind of pain is compression of the nerves in the back. So when you get lancinating pain, almost like a stabbing kind of pain, shooting down kind of pain, that is much more likely to be a large fiber kind of pain. So how do you test them? Once the patient complains of that, it's very simple, right? For the small fibers, you actually test with a pinprick pain, and you can test with the side of your tuning fork or whatever cold thing you have, and that's the small fiber. And the large fiber you test for toe position. So what you do is you hold the toe like this, you ask the patient to close their eyes, move the toe down, ask them where it is, keep the toe down, you try to confuse the patient and find out whether he really has joint position or not. One of the things that patients will complain of if they really do have joint position trouble is that I am very unsteady. I feel like I'm going to fall down, because again, remember, the function of joint position, function of the large fibers is actually to keep control of your body, keep balance in your body. So what if the large fibers are more affected? Why is that important? Why is it important to know? So it's very important because other factors, which most of the time you will be testing for anyway, but other factors become much more important, like B12 deficiency, folic acid deficiency, VDRL, hereditary and vitamin E and copper deficiency. All of this information is good, We'll talk about that. But I'll give you a simple way to approach the problem later as well. So myelopathy, and certainly I think I've seen many patients for whom neuropathy was diagnosed, but they had a myelopathy. It's very important to know whether somebody has a myelopathy or not, because it can be catastrophic. It can lead to quadriparesis. So what is the one symptom of myelopathy that is not present in neuropathy? That is bladder incontinence. If a person has bladder incontinence, think of a myelopathy first. Of course, you can say autonomic neuropathy happens in diabetes and so on, but this is much more likely. One thing in examination, your reflexes will be brisk in a myelopathy, whereas in a neuropathy, your reflexes will be down. All of us have been taught about upgoing planters. So niche, you scratch the bottom of the sole, and if the foot comes up, the big toe comes up and the other toes fan out, then you call it an upgoing plantar. But in studies which have looked at the sensitivity of the upgoing plantars, only 50% of patients with a clear-cut myelopathy had an upgoing plantar. What is the one special thing you can do? One special thing you can do is, you can take a pin and keep on going upwards. The umbilicus is around the T10 level, the nipple is around the T4 level. So at one level, the patient will say, ह्याच्यावरती feel होते, ह्याच्या खालती feel नाही होत. At that point, you are sure that you are dealing with a discrete problem in the spinal cord, a myelopathy, rather than some generalized affliction of the nerves. So again, you can pinpoint and say to the radiologist, "Sir, iska T4 level dekh le." So whatever it might be. So in a patient with diabetes, we blame diabetes, but other things such as HIV or alcohol can also cause this picture. So how do you approach a patient? A patient comes to you. So I think this is a general thing that I do. I do ask for a history of alcohol and factory exposure. For example, lead. What do you do? Check the medications. Ask for a family history, for example, for HNPP and so on. Make sure it's not a myelopathy. Again, we are just on symptom, the history taking. Look for patchy sensory loss and signs of leprosy. I don't do an EMG nerve conduction for most of the time, because EMG nerve conduction is useless in the case of exclusively small fiber neuropathy. It does not test for small fiber neuropathy. You need to do a skin biopsy for it. So in classical diabetic neuropathy, EMG nerve conduction is not very good. Second line, so in terms of investigations, you can do an HbA1c or a fasting blood sugar if the patient has never been diagnosed, a B12, folic acid, HIV and VDRL. These are simple tests. I think you can just remember them. The second line, I think, should be vitamin E, ANA blot and other things which at this point of time you might want to refer the patient to me. So, treatment of diabetic neuropathy. So, in terms of treatment of diabetic neuropathy, it's really like a bhel puri na. क्या चाहिए आपको? इतना सारा दवाइयाँ है. क्या चाहिए? तीखा चाहिए, मीठा चाहिए, कैसा चाहिए? But we need to still make some sense of it. So let's try to make some sense of it. A medication that I've been using very frequently nowadays is alpha-lipoic acid as an add-on. And it almost seems like snake oil, ye kya vitamin वगैरह, but it has been shown to work in multiple studies. Sorry. So it has been shown to work in multiple studies, and it's a simple medication that you can give on, and it's almost as effective as amitriptyline with very few side effects. So alpha-lipoic acid, 600 milligram. I think the brand name that you get is Alafin or something. So amitriptyline, right? Amitriptyline, very cheap medication. I give it for a lot of conditions. In fact, one of the discussions in the Maharashtra Association of Neurology group that we had recently was कि इतना amitriptyline देते पेशेंट को समझेगा ना सब चीज़ के लिए amitriptyline देते. तो somebody suggested तुम brand name सीख लो. Amitrin है, Libotrip है, and what not. So nowadays I have started writing it in different brand names so that each patient thinks, I have given something different. So anyway, the point is it's a very nice medication, and actually that was highlighted to me when I came to India by Dr. Dandavati sir, that it is a very good medication because a lot of our patients are also depressed and anxious and so on, and it helps with all of those things. It is also an anticholinergic though, so you need to be a bit careful about it. It can cause a dry mouth, glaucoma, constipation, and the solution is to use nortriptyline. And the nor actually comes because it's a designer medication which has very few anticholinergic side effects. Duloxetine, I'll quickly go over. It's an SNRI, very similar to amitriptyline. It does not cause as much anticholinergic side effects, but still I've seen one patient with acute angle closure glaucoma with it. Pregabalin, gabapentin, valproate, carbamazepine, all of these can be tried. Just one thing to mention is that gabapentin is probably not very effective, even though we use it a lot. This was an article in the New England Journal of Medicine. On the other hand, pregabalin is effective. But why do we find that many of our patients don't respond to pregabalin? Because of copyright issues. copy or trademark issues or whatever they are called. Many of the preparations that we get in the market is a combination of two enantiomers, the S enantiomer and the R enantiomer, whereas all the studies conducted in the US are on the pure S enantiomer. Now the trouble is that Pfizer does not permit anybody to make the pure enantiomer. So the only one, unfortunately, with the pure S enantiomer is Lyrica by Pfizer. So if a person that you have is not responding to the usual pregabalin, try Lyrica. Very expensive medication though, and I would certainly try amitriptyline first. I don't use too much gels, but sometimes I do. Following combinations have been studied. So pregabalin and duloxetine is the most commonly studied combination, and I think you get some sort of combination now in the market, but you can just as easily give two different medications. The American Academy of Neurology recommends very high dosages for all of these medications, but it's very difficult to give these kind of dosages. So duloxetine, amitriptyline 100 milligram daily for diabetic neuropathy, for me at least, just does not make sense. 25 milligram is usually much more than needed. And again, Sir had mentioned last time that 12.5 actually works well in his patients also. So in this bhelpuri of things, this is my final slide. What do I do? As I said, I recommend ALA to all my patients. It's just a free thing that you get, extra puri dete na waise. It does have some benefit and without any side effects. If the patient is anxious or has insomnia, amitriptyline is a great choice. Duloxetine is also a good choice, but both of them have anticholinergic side effects. So if a person has a glaucoma, prostate, constipation, or sometimes cardiac problems, then use pregabalin. And again, Lyrica is actually unfortunately more effective than the usual pregabalin. Second line, pregabalin plus duloxetine combination, and in some cases carbamazepine. There are other choices to treat painful, symmetric, length-dependent neuropathy of diabetes, but for that, in the terms of opioids or nerve stimulation, I don't do any of those. So nowadays there are pain management specialists who do focus on nerve stimulation and nerve blocks and so on. I think at that point of time, referral would be a good idea. And that's it, my turn. Any questions from my side? Thank you so much to IMA Virar for giving me this opportunity to talk in front of you. And if there are any questions, I'll be happy to take them later also.